Well, welcome back, everyone. We're close to the end of this program with the most serious of all the brain disorders I've discussed so far, and that would be schizophrenia. There's lots going on with this that's so interesting and is closely associated with estrogen. In addition to some notable gender differences, there's what's called the, quote, estrogen hypothesis. That's a theory behind what's believed to be impacting the development and progression of this disorder. I'll explain it all as we move forward. Schizophrenia often includes some aspect of psychosis, and you'll be surprised to learn about how estrogen is being explored as treatment for this condition. But of course, estrogen has its issues, so there's also work being done in exploring the use of SERMS rather than estrogen. Really interesting stuff. So let's begin. Okay, let's begin with the estrogen hypothesis. Since the late 1800s, doctors have noticed something interesting among women who were experiencing psychosis. Their symptoms appear to fluctuate throughout the menstrual cycle, especially during the mid to late luteal phase when estrogen levels were lowest. In fact, it was termed, quote, the menstrual psychosis, unquote. Also noted was a significant increase in admission to psychiatric hospitals for these women during that phase of their cycle. Over time, this observation became known as the estrogen hypothesis. And it was actually first introduced at the beginning of the 20th century when early researchers observed signs of, quote, insufficient functioning of the sexual glands, unquote, and also, quote, chronic hypoestrogenism, unquote. And they noticed this in their female patients with schizophrenia. I don't know about you, but I was pretty surprised that this has been around for quite a while, and I never actually heard about it. So studies show that when compared to women without psychosis, women with early evidence of schizophrenia have low estrogen and high testosterone levels. They're also more likely to experience menstrual irregularities, anovulation, infertility, and signs of hyperandrogenism. In addition, low circulating estrogen levels have been associated with more severe symptoms and reduced cognitive ability, especially in regards to verbal ability and executive function, an example of which would be the ability to make decisions. Interestingly, there's an overall improvement in symptoms during pregnancy when estrogen levels are high, but worsening postpartum when estrogen levels begin to drop. As you've learned throughout this program, estrogen is a hormone that impacts many of the brain's neurotransmitters, including serotonin, dopamine, norepinephrine, all of which are involved in the development of brain illnesses, including schizophrenia and depression. I think this slide does a nice job in highlighting the connection between these neurotransmitters and estrogen. And once again, it's not likely that estrogen is the only factor involved in these conditions, but it's becoming increasingly apparent that it plays a very important role. So, the bottom line is this. The estrogen hypothesis is a theory that suggests the hormone estrogen has a protective effect in women who are vulnerable to developing brain diseases and very specifically schizophrenia. Interestingly, the negative correlation between plasma estrogen levels and schizophrenia symptoms was also reported in male patients. Because remember, they too have serum levels of and brain levels of estradiol. Well, when most people think about schizophrenia, the symptoms that come to mind are hallucinations, disordered thinking, but there are actually a whole range of symptoms associated with this disorder, and some of them are gender specific. I had brunch a while ago with two of my very esteemed colleagues in nursing, and the topic of schizophrenia came up, and one of them said, "Isn't that when people hallucinate?" And I thought, okay then, I better do a quick review of symptoms in this program. There are three main types of symptoms in schizophrenia. They're defined as positive, negative, and cognitive. Positive symptoms include bizarre trains of thought, hallucinations, delusions. This is what many people tend to associate with schizophrenia. But then there are what are called negative symptoms. These include apathy, poor rapport, lack of spontaneity, motor retardation, disturbance of volition, blunted affect, emotional withdrawal, and passive behavior. And finally, there are cognitive symptoms. These include distractibility, poor attention, and working memory deficits. In addition, abnormal circadian rhythms have also been observed in patients with schizophrenia. And knowing what you know now about estradiol and circadian rhythms as well as cortisol, you could really begin to put the pieces together and see where it all sort of fits. Okay, so interestingly, delusions and paranoia have been found to be more evident in women's experiences of this disease. Women have been also shown to have more anxiety, illogical thinking, and inappropriate affect, different than men might have. Men, on the other hand, tend to have more symptoms around being disorganized. The research we have so far has identified even more interesting gender-related differences. So, with late-onset schizophrenia, women may have less severe negative symptoms and present with more positive symptoms, particularly sensory hallucinations and persecution types of delusions. There are also additional differences between men and women when looking at the ability to function socially. Women did much better than men. They were more likely to be in a relationship, whereas men were more likely to be single and childless. Men were also more likely to abuse cannabis and alcohol, more so than women. But women are more prone to addiction and have more difficulty coming off these substances. Problems with the ability to learn and process one's thoughts and experiences are usually present long before the onset of psychosis. Being able to understand metaphors used in speech is often problematic, but some symptoms might be less dramatic and include apathy, blunted affect, limited speech, social withdrawal, and an inability to enjoy activities. My personal opinion is that we try to box people into neat categories with a heading called schizophrenia, for example. But as I mentioned earlier in this program, these are more representative of symptoms rather than specific diseases that we can neatly put in a box or create an algorithm for. And that's why I think there's so much conflicting information and research findings out there. There are possibly a variety of physiological bases for symptoms that we call schizophrenia. And when research is designed as if they are all the same, we end up with lots of conflicting results that are difficult to interpret. Because, hey, once again, it's complicated. So age is a significant gender difference when we talk about schizophrenia. Women tend to be 3 to 5 years older than men when they first experience psychotic symptoms. Their first admission to psych units is also later, by about 3 to 6 years. There isn't really a consistent incidence rate for gender differences, although there is some evidence for males when they're younger and for females when they're older. In fact, there appears to be a bump in incidence for females that occurs around age 45. And hey, guess what else is going on? That's right, their estrogen is decreasing during those ages. So what may have been protecting them earlier is now providing an opportunity for those genes to express themselves. There are clearly lots of differences between men and women when it comes to schizophrenia. And honestly, we're not even sure that this is all the same disease. In time, we may learn that there are even more significant differences. We already know that there are genetic factors involved, and we'll hopefully learn more about other endocrine factors, as well as brain abnormalities and possibly environmental factors that might also be involved. All of which may take us into some very new thinking about what these symptoms really mean and what they really represent. So if we believe in the estrogen hypothesis, then the next reasonable question might be, why not use estrogen as treatment? Well, in 2009, Professor Kulkarni began publishing really extraordinary research about the potential for a different kind of treatment, and that would be using estrogen. Her research is based on the estrogen protection hypothesis, sort of a version of the estrogen hypothesis. The ADEPT study was her study, and it was the first large-scale randomized controlled trial done in women with treatment-resistant schizophrenia. Your slide provides the major details of the study, and note that transdermal estrogen was used and not oral estrogen for lots of reasons, but most importantly, you avoid all of the complicating issues that come with oral estrogen. For instance, going through the liver can create all kinds of issues. So the patch is a lot cleaner and neater and limits those complications. Both estradiol groups had greater decreases in positive, general, and total symptoms compared with the placebo group. And there was a greater effect seen for those using the 200 microgram as opposed to the 100 microgram of estrogen. Pretty impressive, huh? So, schizophrenia is typically treated with antipsychotic medication, sometimes also electroconvulsive therapy and psychotherapy. But women with schizophrenia who take antipsychotic meds have a specific problem. It's hyperprolactinemia. Prolactin is a hormone that's made in the pituitary gland. It's the hormone that's responsible for helping women to breastfeed. The name kind of tells the story, prolactin or prolactation. Usually if women are not breastfeeding, they have low levels of this hormone, and the same is true of men. But when women take antipsychotic medications such as, say, risperidone, a specific dopamine receptor in the pituitary that's responsible for regulating the production of prolactin is blocked, and that results in too much prolactin getting produced. this can have significant long-term side effects. Women have greater or higher risk for diabetes and men for hypertension. It's important to note here that compared to young women, postmenopausal women typically required larger doses of antipsychotics given the decline in their own endogenous estrogen levels. So these negative side effects are even more pronounced in older women. Another side problem associated with using antipsychotics is especially interesting. Since these drugs increase prolactin, they also decrease estrogen. This is part of the reason why many women, when they're breastfeeding, no longer have a period during that time because their estrogen levels are low. Now, if low estrogen levels are indeed part of the chemical imbalances creating schizophrenia, using antipsychotics might make some of the symptoms better, but ultimately be creating an even more low estrogen environment in the brain that will continue the imbalance that created schizophrenia in the first place. When a woman wears an estrogen patch, in addition to her usual antipsychotic treatment, her acute psychotic symptoms often improve. As I've already shared with you, this has also been observed when women include estrogen in the treatment of various depressive disorders. And as we've seen in those instances, there's often significant improvement in mood-related symptoms. That same improvement in symptoms occurs in women diagnosed with schizophrenia. So it's a combination of using the typical drugs used for treating these conditions along with estrogen. But the use of standard estrogen treatment, of course, as I've mentioned already quite a bit in the program, isn't without health risks. It's been linked to blood clotting disorders and increased risk of developing tumors in the breasts, ovaries, and uterus. One bit of good news, however, is that the patch does not appear to increase the risk for blood clots in postmenopausal women. Now, as I went through the research journals looking for evidence of estrogen's effectiveness for schizophrenia treatment, I discovered a review of 6 randomized controlled clinical trials, the gold standard in research, that had a total of 426 women enrolled. Women were either given only the antipsychotic medication or their usual medication along with estrogen. The results showed that women treated with estrogen had significant improvement in their symptoms compared to those who just received the antipsychotic medications. With the goal of seeing if these results could be replicated, a different set of researchers administered estrogen patches to premenopausal women with schizophrenia for 8 weeks. They also reported significant improvements in positive symptoms, and that included delusions and hallucinations, as well as negative symptoms such as lack of initiative or poor social ability. These effects were pronounced in women between the ages of 38 and 45. Once again, the ages when estrogen levels are dropping. In all of these studies, the estrogen used was estradiol. This is not the estrogen found in birth control pills, nor is it the kind of estrogen usually taken by mouth. For example, it's not a conjugated estrogen such as Premarin. Those estrogens don't have the same effect or potency on the estrogen receptors in the brain that estradiol has. And by the way, neither does estriol for those women who have been led down the path of compounded hormone preparations. Another issue that presents itself when using estrogen in women with a uterus is the need to protect the lining of that uterus from overgrowing. This is usually taken care of by taking a progestin of some kind, whether in a birth control pill or a hormone therapy during menopause. Again, as I've already shared with you, when a progestin is added to estrogen, it reduces the positive effect that estradiol has on those receptors in the brain. This is one reason why investigators are now looking into using SERMS, which I'll address in a moment. But one last thought here. It's possible that men with schizophrenia might also benefit from using estradiol. But there are obvious concerns related to the potential, for instance, feminizing side effects of estrogen. It's interesting to me, as I ponder some of these findings, that many of these men drink alcohol as a form of self-medication. Alcohol, we know, increases estrogen. And this might be the positive reinforcing effect associated with men drinking alcohol excessively. So interesting to connect the dots. Okay, then let's take a look at SERMs. The term SERM is short for selective estrogen receptor modulator. These are drugs that are synthetically produced to have the same binding effect on estrogen receptors as estradiol, which would be the natural estrogen produced by women. What makes these drugs better is their ability to be selective. In some parts of the body, such as the breast, a SERM like tamoxifen can bind to estrogen receptors in that location and prevent the more potent estrogen in a woman's body, naturally produced in a woman's body, from stimulating those receptors. This has been incredibly helpful in trying to treat and stop the progression of breast cancer. Unfortunately, although they have a positive effect for breast cancer treatment, this same drug can stimulate the estrogen receptors in the uterus and potentially cause problems, not the least of which is uterine cancer. So depending on what part of the body is being targeted, and knowing that the blood carries this drug throughout the body, a SERM can have both a positive and a negative effect or impact. There's another SERM, raloxifene. It was produced after tamoxifen, and it works in a similar way. It was created to avoid the negative effect on the uterus. In the brain, raloxifene has a positive effect, similar to natural estrogen. It appears to affect several different neurotransmitters, including serotonin and dopamine. It's also protective in the breast, but in addition, it also has a positive impact on treating osteoporosis, similar to the way estrogen protects bone health. The addition of raloxifene to regular antipsychotic treatment in postmenopausal women with schizophrenia who exhibit prominent negative symptoms significantly improved these symptoms, as well as general psychopathological symptoms when they were compared with women receiving just the antipsychotic medication alone. That being said, there's also some findings that raloxifene might not have the same positive effect for women who are more severely decompensated with schizophrenia. And the dose that was used in these studies, in most of these studies, was 120 milligrams a day. But just like tamoxifen, there's a potential downside to using raloxifene. There's evidence that it might increase the risk for a blood clot that could lead to a stroke. Of course, this depends on the dose being used and the risk factors already present in a woman using it. Because, once again, it's never simple. It's complicated. But remember, all drugs have benefits and risks, and often no treatment at all carries a very significant risk. There are many factors to take into consideration. Remember, antipsychotic drugs can put women at risk for diabetes and men at risk for hypertension, so they're not out of the clear either. Recent studies have shown that using raloxifene along with these drugs can lead to a reduction in the dose of the antipsychotic medication and possibly lower the risk for side effects down the road. So similar to adding estradiol, raloxifene has also been tried as an additive drug along with the antipsychotic meds. In fact, a large meta-analysis found a 10% decrease in mortality for patients taking raloxifene compared with those receiving placebo. When investigators sat down and analyzed the findings from a bunch of these studies, and basically created a meta-analysis, they came to the conclusion that raloxifene does in fact improve most symptoms associated with schizophrenia in both males and females. But of course, the research continues, and as it should. But for many with this disorder, there's a great deal of hope now in the prospect of using estrogen or a SERM like raloxifene to help them live a better life. This next slide shows some of the statistical details for those of you who might be more quantitatively oriented, associated with the large study done by the Australian group. It's pretty impressive. And before I close this section on schizophrenia and estrogen, I'd like to share a case study with you that was reported in the March 2018 issue of Current Psychiatry. It describes a 51-year-old single woman with schizophrenia who had been living in a residential treatment facility and doing quite well. She was stable on Haldol for years, but suddenly she became very agitated, threatening her roommate, yelling during the night. She was refusing her Haldol and was also refusing to attend her outpatient appointments. So she ended up being admitted to an inpatient psych unit where she stayed pretty much confined to her room. During the times she came out of her room, she would yell or cry out and talk to herself. She didn't engage with anyone, and when the docs tried to speak with her, she would just remain mute. At this point, she was on a bunch of various antipsychotics, most of which I can't pronounce, so I listed them on this slide. This went on for about 2 weeks. She refused to talk to social workers about her plans regarding discharge, and often just remained in her bed for long periods during the day. Despite increasing the dose of Haldol, there was minimal improvement. All of this was surprising because when her past records were reviewed, previous hospitalizations were very different. The average stay was shorter. She generally was able to converse with the treatment team, participate in discussions about her care, and make decisions about her discharge. So they were trying to figure out what made this admission so different. Then the possibility of menopause came up. By now, she had been on her unit for 2 months and had not requested sanitary pads. There were also reports from nursing that she was feeling flushed and sweaty without any fever or signs of infection. Since she didn't have a history or risk factors for thromboembolism, the docs decided to start her on raloxifene, figuring the benefits outweighed the risks. Over the next 2 weeks, she became increasingly interactive with the staff and was seen sitting at a table talking with other patients on several occasions. She was observed looking at fashion magazines and discussing fashion with staff and other patients. She participated in group therapy for the first time during this hospital stay and began to talk about discharge. She even occasionally smiled and waved at her treatment team. Just 2 weeks on raloxifene turned this episode completely around, and she was able to be transferred to a facility closer to her home. Now, as much as this sounds miraculous, and it clearly was amazing, this treatment may not work for everyone for all of the various circumstances I've already discussed. But it really is a huge breakthrough for a disease that can be so incredibly disabling and really underscores how important estrogen is for maintaining brain health. And with that, this concludes the section on estrogen and schizophrenia. We're getting close to the end. The last section will cover some bits and pieces of very early research on 2 other areas that I thought would be interesting to share with you. So we'll see you in a bit.